They're laughing.
All right, we got a thumbs up back there from the aqua shirt. So let's call the meeting to order. And Shane, we need to establish a quorum. We have a few members present and you have some members that are just viewing today. You want to fill us in on that?
Yep, I'll go ahead and do roll call. Dr. Box,
Here.
Dr. Monroe,
Here.
Senator Kenley,
Here.
Dr. Maxey, Mr. Ellison, here, Mr. Tabor, Dr. Veal,
Here.
Ms. Irwin,
Here.
Ms. Waldron,
Here.
Dr. Halverson,
Yes, sir.
he's online, Dr. Kane. I will note that Mr. Tabor just joined. Dr. Welsh,
Present.
Commissioner Bardsley,
Here.
Mayor Courtney, Commissioner Dawes,
Here.
and Congresswoman Brooks is online.
Here.
We have a quorum.
Thank you.
We're not seeing it, Shane. Do you need to come up and do something to the computer?
I think I'll go ahead here. Normally your executive committee meets and we were here earlier and we try to get things prepared for the meeting. And today we're going to review the proposed recommendations. And I can't tell you how appreciative Dr. Monroe and I are of all of your attendance and participation and feedback and the work that we've done over almost a year now. And I think we have a remarkably good product to define what we want to do and what we'd like to recommend to the governor's office. And we have taken the liberty of discussing with some of the governor's people, some of the elements of the report to try to make sure that we're not putting them in an untenable position, something that they can't accept or they won't like. And so we talked earlier and we decided that we would like to go through the agenda and cover everything and cover all the issues that we have with the report. And then also we're going to have a little discussion, which I'm going to try to help lead on the proposed funding model that we're going to use. We'd like to, if possible, go through this today. And if you feel comfortable, we'd like to consider taking a vote to approve the report, perhaps with some modest changes being made on this point or that point in certain locations of the report so that you won't have to come back for another full meeting. I think the governor and his people, I know they've asked about how our attendance has been at this meeting, and they've considered it really remarkable, the high level of attendance that you all have given us every month, month after month for 10 months now. So if that works out, well, we'll try to do that today, and then you won't have to have another meeting. And the only thing you'll probably have to come to will be the party that Dr. Box is going to give to thank you all for serving on the commission. She didn't know I was going to say that. So, but you all have just done a great job. We can't thank you enough, and we can't thank the members of the department too, who have made preparations and given us presentations. And I think this has been a remarkable exercise on an issue that really is in the forefront of what Indiana needs to address next in terms of what we're going to do to make our state the good, well-run, well-managed state that takes care of its people in the way that we want to do. So I can't overstate my appreciation for what you've done, and hopefully we can proceed on that basis today. If we get bogged down and the conversation is a little difficult, or we need to do something else and have another meeting, well, we'll just do that. We'll make sure we've got a good work product ready to go. So before we start on that, I'm going to ask Dr. Monroe and Dr. Box if they have anything to say. I think Congresswoman Brooks is tracking with us today, but she's waived her right to make an opening statement since she's not present. So Dr. Monroe.
Well, let me echo my thanks. I mean, it's been such a privilege to serve with you all, and it really has been remarkable, the attendance and the attention to detail and the commitment and the great dialogue that we've had. So I also have to say it's always great for me because I travel in from Atlanta to come to these meetings. So it's always interesting to see what's happening in Indianapolis when I arrive. So y'all might be aware that the 2022 USA volleyball girls big junior national championship is taking place, and they're like all in my hotel. And they're all on the elevators, and good luck getting an elevator or good luck getting Starbucks because the line's really long. But one of the things that wasn't lost on me was when I was trying to figure out who all these young folks were and their families, they're like the picture of health, right? I mean, they're volleyball players. It's like, oh my gosh, this is like the picture of health. And so I was reading a little bit about it, and I saw where the Inside Indiana Business reported out that this could generate $60 million for Central Indiana. It's a nice example of health and wealth, or how health is a driver of the economy. And as we all know, I mean, public health has never been a bigger priority than it is right now. And we're seeing that play out across the country as state and federal organizations are taking a hard look at the lessons that they've learned from COVID-19, the pandemic response, to improve how public health services are delivered here in Indiana. So important. And Indiana's really been a thought leader in this area, thanks to the commission and other work. And so I really look forward to discussing the final recommendation here with you all today, and how they can be transformed into truly actionable steps to improve the health of Hoosiers.
Dr. Box?
Thank you. First, I want to start by thanking Senator Kinley and Dr. Monroe, all your travels back and forth, and Congresswoman Brooks, who's online with us, for your incredible leadership for this commission, and all of you for being here and participating and engaging and really being an active part of this process. I do think, though, we need to also include in that our designated policy advisors who have worked so hard to provide this information and this research and the background. I want to make sure that we thank our staff, Kathy, who has been over here taking notes, compiling things, writing a lot of this, and her team, and Shane, who has really worked his behind off to make the changes, to tweak the things, and to really improve this report. So just incredible amount of work that's gone in. I do want to point out that this is still a draft. It'll go out today, publicly be available, but what happens today is it will immediately be obsolete because we will be making changes today to this based on what you say. I also want to thank Judy. I'm sure you had something to do with it, but we were chosen as one of the 21st century states, one of 18 states in the nation that is coming together to work on public health transformation and work together. And I've always said I learned the most from being with other health officers and other public health people from across the United States about what they're doing. Everybody's in various stages. Everybody's approaching this differently, but we're learning from each other, which is really, really key and important. And a team, along with myself, just got back from DC meeting with them. So we're very excited in that process and how we're working forward. But their key topics, believe it or not, are data integration, community and stakeholder partnerships, workforce, funding, and other topics. So exactly where we started is exactly where we've ended up and where they are also. So I think really important. And the CDC has also recognized the importance of what states are doing and being able to fund that going forward. So you may have seen that there was a big notification of funding opportunity that recently came out, that Indiana, I am really proud to say, will be one of a few states that are applying as an entire state. Every local health department and the State Department of Health will all be working together to apply. There are some states where the local public health departments apply separate from the state, apply separate from their INSACHO, so their state health officer organizations. And really, we are working with all of our key stakeholders to come together for this. And it really does have quite a bit of money for public health infrastructure and workforce, and ensuring that there is the ability to deliver public health services in every one of our local locations. And I think the important thing is that this will give us a great start and a foundation to work toward where we are headed in 2023 with our legislative sessions. So we're really eager to pursue this opportunity and are already working very hard on it. And we'll have a lot of our partners working with us as we apply for it. And the good news is we heard very clearly that oftentimes grants are too restrictive and many of our local health departments will not take them. these grants are very, very non-restrictive, and our granting out to local public health will be the same way, because we want to support what local public health needs to raise their level of delivery of services and workforce. So we're excited about all of these prospects, and most of all, I'm excited about the final report that we'll get to the governor. And I want to once again thank you for your involvement and your engagement.
Thanks for mentioning that about the volleyball. As I drove down to the State House complex, I saw 2 or 3 sets of really tall young ladies. And I thought, wow, I can't figure out what's going on here. So,
There you have it.
one other issue it's going to have a bearing on things as this develops and goes to the governor's office, and then they try to put some recommendations together for the budget next year. And that is all of the news and all the media information that you're seeing about the recent decision in the Supreme Court case of Roe versus Wade. And of course, that involves public health in some ways. And we have tried to prepare a plan that is deals with public health and healthcare prevention that will be operative all over the state of Indiana. The legislature is the body that has the policy decision-making responsibility with respect to that issue. And so that may impact our report at some later date in some way, and maybe parts of other discussions, but I think we've tried to develop a fully complete program. And so without some guidance or some direction from the legislature as to what the statewide policy is going to be, I think we're going to just kind of move forward and probably not deal with that issue specifically. And so if some of you have some feelings or thoughts about that, well, I think that's the protocol that we probably would be best to follow at this time. So if we could get your cooperation on that, I would appreciate it. Let's see, we need to have the minutes approved. Is there a motion? So
Motion to
moved
accept
by
the
Dr.
minutes.
Welsh and seconded by Carl. Thank you. Can we approve the minutes as delivered? All say aye.
Aye.
Thank you. Next item on the agenda is the public input summary. Shane, you have a report for us?
I do. We had 26 comments over the last period. A large majority of them were actually related to school nurses and support for recommendations around that. 18 or so specifically spoke on the need for better funding, as well as for salaries, but also supplies, and expressing a need for better training standards and guidelines. And one respondent actually said that they appreciated all of the recommendations we had on adolescent child health integration. We did have 3 folks express opposition to the expansion of public health authority relative to collection of information, parental consent concerns, and stuff related to the pandemic response, as well as one person who expressed concern about vaccine mandates. We did get separate comments from individuals representing Fisher's Health Department who expressed support for our proposed changes around local health officer requirements, as well as connecting local health departments to regional experts or subject matter experts in the medical setting. And that same respondent also reported wanting to express support for municipal health departments and not eliminating them from the potential delivery system. There were several other recommendations that were only just a couple folks responding. So I encourage you to take a look at those, but that by and large was what we received this past period.
Any comments about Shane's report? Seeing none, let's move on. Next item is the kind of a proposed funding model that I have put together. Let me give you just have the members had this prior to today? Is this the first look at this?
I sent it out yesterday.
So yesterday, we gave you
Sorry, guys.
barely an opportunity to take a look at this. And if you have, I'm appreciative. Let me walk through my thinking just a little bit on this, and we need to get your reaction, your comments about this. As we worked through the year, it seemed to me pretty clearly that we've relied for so long on the local health departments to be our connection and our provider with the public. And I think that despite funding limitations and all other types of things, that they probably represent a very good way to do this. And so I think we need to have a partnership arrangement where you have the State Department of Health. And we've shown that because of the large number of counties we have with smaller populations that need some expertise to be available to them, we think staffing up the 10 regions to be of assistance to all of these local health departments is going to be a good thing to do and a wise investment. And then in order to complete the circle on a true partnership arrangement, we not only have to engage the local health departments and have them be a partner with us, but we actually need to have local government officials in each county to agree with and work with the whole program. And so the concept that I've come up here would be that whatever level of funding that we're going to ask for, and what we're thinking about asking is to bring Indiana in line with the national average. I'm going to take a page out of Mitch Daniels' playbook here. When we went through the first recession, he had a meeting with all his cabinet officers and some of us from the legislature that were control the budgets. And he said, okay, we're going to cut everybody's budget by 3%, but we're not going to deliver 3% less services or any less services. We're going to deliver more services. And this is the challenge that I'm putting in front of you. So I want you department heads to figure out how you can actually do a better job, but you're going to decide where you're going to cut 3%. And there'll be no exceptions, he said. So we think that if Indiana is given the opportunity to have funding equivalent to the national average, that because of our past record and our ability to do things like this, that probably we will get more for our money than most people would have. And if we do that and achieve those funding levels, and if we see other needs that are out there in the future, then we can turn to those specific programs and decide how you want to fund them and what else we need to do. So the funding would be asked for to be granted to the State Department of Health. The State Department of Health would put out a plan and working through the 10 regions and with the counties to fund up the activities in the local health departments. And we're asking the counties to participate in a way which is parallel to the way we've had funding with on our road funding program in Indiana for many years. And that's where they kind of have a copay. And the copay could be, as I suggest in the thing, it might be from 10% up to 20%. And we could probably design some kind of an equity formula based on people's ability to pay. We have done that in our education K through 12 funding formula. I designed a way to do that, to measure people's ability to pay in different counties, different communities, different school corporations. And we've been doing that for about 20 years in Indiana. And actually, by the analysis of some of the think tanks around the country, I've seen it quite often listed that Indiana has, if not the best, one of the 5 best formulas in the nation for getting the money from the state to the places where the need is the greatest on a per pupil funding basis. And so trying to build on that experience, I think we can apply the same type of an approach to funding with the local health departments. And in order to ensure that the local elected officials are in agreement with the program, we would ask them to take a vote as to whether to participate in the amount of funding that we're talking about, which is a pretty significant amount of money. It's on a statewide basis, it's almost $250 million. And so we would ask them to vote to participate in the program. And then if they do that, we would expect that they would be pay their fair share based on some kind of a copay arrangement to be put together. Now, I know this sounds a little vague right now, and I'm sure folks like Mark and Dennis that are on these bodies are saying, well, wait a second, what about this or that? Those are all things that need to be worked out. And I'm just kind of trying to outline a general program of how we would go about doing this. And so the counties that opt in, then they would be able to participate in the program that we have put together. And this would be the skin in the game that they have. There's been, in recent years, there's been some problems with sending funds from the state down to local levels, and then the funds don't end up being used in the health department. And we would design this formula so that there would be safeguards. In other words, the counties would have to meet their fair share obligation. The county elected officials would not be able to pluck the money out of the health department and set it aside for some other unrelated purposes. And it says funding would be delivered on a county by county basis. Any spending by the county at a subunit or a city where we have these grandfathered exceptions that we've allowed so far may only be done with the agreement of the Indiana Department of Health. And funding can only be used for the local health department and be released to the local health department, and it can't be diverted. So once a county agrees to participate, it must remain in the program for 4 years. And then any county not in the program will not be eligible to receive funds from the Indiana Department of Health. And we've had in our executive committee a lot of discussion about, is this the way to do this, or how do you make this work? I have talked with some other people who I've worked with over the years, who worked in governor's offices, ran budgets for the governors and different kinds of situations. And they feel like this is the way that you have to get buy-in. You have to get somebody to say, yes, we're going to participate. And then they have to come along with that. And we think that because of the sheer value of the program and the opportunity to have funds available to do this correctly, we think that pretty much everybody's going to sign up. Now, somebody like Dr. Monroe or Dr. Box, who have run a list of patients, they may be a little concerned about what's going to happen if somebody says, I don't want to be in this or that. And I think that this is the way you have to do it, that this helps to produce the partnership effort that you want. And secondly, just being realistic in a political sense, as we have gone through this issue with the pandemic, and we've had these debates, discussions, arguments, and fights back and forth about, well, the governor shouldn't do a mask mandate, or the governor's telling us to do this or do that or something else, or what about vaccinations, or what about decisions by local officials. We're trying to avoid that kind of a situation by making sure that everybody who's in the program wants to be in the program and they want to participate. And so I think legislators, for example, they passed a bill a couple of years ago, and I know that Chris can help me articulate what the bill said, but basically they passed a bill that said that any mandate that came down from the state, that the county could challenge it and decide not to follow that. Well, we're putting together a complete comprehensive program here. And I feel like that if we put in there that they have the option of making a decision on their own as to whether they participate or not, in this program that we're offering, that if their local elected officials have that option, then I think many state legislators who had concerns about decisions that had been made or how something came out or how it was being handled, I think this kind of takes away their argument that we are forcing or mandating counties to do certain things. And so I think it helps promote the partnership arrangement, which if we can get everybody to have that attitude, obviously it's going to work better. But also it takes care of that political friction point in terms of getting a bill past the legislature. And I know Dr. Box is tired of hearing me saying this, but everything that we do here and all the work that we put together and the recommendations that we make, it doesn't mean a thing if you don't get 26 votes in the Senate and 51 votes in the House and an appropriation in a budget bill. And so those are the things that you have to do to get this accomplished. And so this is my effort. I won't put the blame on anybody else to come up with a way of doing that. So the floor is open for discussion, pro, con, or otherwise. Yes, Dr. Welch and then Mindy.
I really like the basic concept that you lay out, especially since it's been used in other areas. So people have a track record that they can refer back to. I have one, putting my county health officer hat on. If this were, say you wave your wand and this goes through and everybody signs on, would that have any effect on local departments applying for grants like they currently do, or would this plan preclude that?
No, it would not preclude it. In fact, I think it would make you better prepared to be able to apply for these grants, receive them, write to them, and then report out on them. And the hope would be that there'd be district people there to even assist you with some of that.
Great, thank you.
Mindy?
I aligned with Dr. Welch. I like the concept. I do like the skin in the game thing. Couple of concerns I have would be with the model, the ability to pay, as you called it, would it ensure that no county amount had to be higher than it is now? So for example, we pay, I mean, I just did the math right now, thinking even 10% being on the low end, 20% concern me because we don't even reach that per capita now. And with the tax caps in place, they'd have to rob Peter to pay Paul. So would you build it in that it would be some either not less than or something along that line? So for instance, if you said ours was 10 or 20% or 15, however it came to be, we get just 3.2 million-ish in tax levy money. So 50% of our budget, that's it. The rest is all other. So out of that, if you calculate that by 380,000 people, that is 17%. So that'd be in the middle, but it wavers. And some counties are well below it and some are well above it. I don't worry about the above it because they're very lucky. But the belows, like if you said 20, we would be able to meet it. And my county would probably opt out saying, well, we can't give you 3% more, or I'd have to take it from X department. That'd be my only real concern, other than in the last part you had, if they opted out, they wouldn't be able to get IDOH money. I misunderstood because he was asking if they could apply for grants. That's the only kind of money we would get other than this programmatic money. Is that what you mean? Like they couldn't get any of that until the next buy-in period? Is that what you mean? I don't have a problem with that.
Yeah.
I'm just wanting to make sure that we're not throwing the baby out with the bathwater and saying they couldn't get any. So in the event that COVID or monkeypox happens in that 4-year period, and we need that, or we need supplies or the meds or something, could we do a little asterisk that says unless some major catastrophic thing?
Well, let me put it this way. First off, I think it would be helpful to have Dr. Box, and she might even consult with some of the local people about that specific problem and maybe come up with a little wrinkle that would help answer that
Disclaimer.
question.
Yeah.
But secondly, the outline leaves a lot of blanks on some details, obviously. And my feeling is lay out the basic model, the basic theory behind the model, and then let it be subject to the process that all legislation is subject to. Because no matter what we do on the points that you've raised, I'm sure that different legislators, either at the behest of maybe their local county elected officials, or maybe on their own initiative, are going to say, well, this might be a problem if you don't do this or do that. So I think it has to be a concept that has the flexibility in it that can be developed to answer those questions. And I know that doesn't give you
That's
a
not
firm answer, but I think that's the way it's going to end up working anyhow.
I just learned that I don't like to worry about unintended consequences.
Yes.
So that'd be my only one. Otherwise, the concept
Okay.
is pretty sound.
I think the goal would be, and we talked about this, and Shane and I even crunched some numbers for counties across the
Okay.
state. Most everybody was safe within a certain amount. And I think the goal is to make sure that maintenance of effort is continued,
That they couldn't.
that
take
they
it
don't
bullet,
go,
except- yeah.
if you spent this much the last 5 years, that all of a sudden you don't go down and you're spending, a third of that or
makes
a small percentage of that. So we would have to really look into that closely. And the goal is to make it available for every county to be able to have.
And you're
this.
right about the elected official buy-in. I mean, we do need that, the three parts of that big pie to make this happen. We can't have that friction.
Right.
going
We
forward.
need them to agree. And I think if most of like in the road funding, I know that many of our local elected officials they're thrilled with the idea that they just have to come up with a certain share, and it's usually a pretty low copay. And so they're willing to work with us on that. And I think it's proven to be a way that we can get there. And just as an extra point, Dr. Box and I have visited with a lot of different interest groups and made presentations to them. And I see Claire there, and I was at the Indianapolis Chamber of Commerce, and they had a forum. And so we've tried to get to a lot of groups to talk to them about this. And we've tried to talk to our local elected officials specifically, and we've had some help from Mark and Dennis to get to those people. But even last Saturday or Friday, Dr. Box and I went down to Bloomington for a second visit with county council members. So we are working this as hard as we can and expect to continue to have to do that selling effort in order to get there. And so that's kind of a part. I mean, the way we do it is something, but we don't want it to come down as something that we have just dreamed up, put in a report and say, this is the way it is, without having talked to them numerous times about how did they react to this or how would they react to that. So Dennis?
I think Kara was probably first.
Okay, Kara?
Well, going back to the local elected officials, I think that's one reason we need to see the education piece that we've talked about previously, by providing the education about the importance of public health with our local elected officials, so they understand the necessary steps to buy into or opt into these programs. I have a question about the road funding program, just because I think, if we could see some trends from that. Do all counties opt into that program, or are there some that don't? And if they don't, what are they experiencing in terms of their?
Well, that's a fair
Their quality work,
question.
I mean-
From my experience, I don't know of any county that has not participated in some way, shape, or form in the state road program. It's become an embedded part of the infrastructure maintenance that we have in this state. And you rarely hear criticism or complaints about who's paying too much or something like that. Most of the time it's how much can we get done for the dollars that we have
Right.
available. So it seems to me that it's been a pretty successful effort. But
And the reason I was asking is because I would anticipate that rolling out a program similar to that would result in similar buy-in or opt-in or
Yeah.
declination of participation in the program for the public health funding. So I get it that it's not apples to apples, but I did think that there's probably some similarities we can assume.
I think you're right.
Well,
Yeah. Okay.
Yeah, just a couple of comments. I think Fox may have answered comments, but on, I think you said earlier, scenarios, and it looks like everybody probably would meet that since it's a 4-year commitment, what if on the 3rd year they can't meet it? You know, they get 4th year. So just, you know, I know the details have out, I understand that. The other ending this, but if you opt out and you're not in the local health department in a county, basically is making it be met, whether you have money for staff program, they don't sign up for the 4 years. Well, we'll do 3 of the 10 requirements, but we're not going to do the other. How is that handled? So I think that is perhaps something to think about as well. I can't imagine a county on functions that need to be performed saying, no, it's a thought.
And what we do know already is that many counties perform these services at various levels, and some of them perform some of the services not at all, just based on the fact that they are so poorly funded and staffed and resourced. But I'll let Senator Kinley answer the thought process. on the other.
That's a good question. And I'm not sure I can give you a conclusive answer, but I can give you some thoughts. One thought is some of the requirements of what they're supposed to do are statutory obligations.
Right.
So they're going to have to meet those requirements one way or another. Another somewhat similar situation that we went through, and you may remember this, Dennis, but when we wrote the property tax reform bill, the reason why our system had been declared unconstitutional was that there was a lack of equity in the assessment process, not only between counties, but sometimes between different areas within a county, because you had trustees doing all the assessment. And so one trustee would, he liked the farmers a lot, so he didn't bother to count their personal property to see whether they had anything to be assessed. And the other trustee was just bird dogging them constantly. And so we had a huge inequity in assessment practices of all kinds. And so what we did was we required LSA with the more modern computer age, all assessments had to be sent into the data bank. And then LSA at the State House, Legislative Service Agencies, they had a division that ran a equity of assessment system to determine whether the assessments were in line with everybody else or not. And then, so there is a precedent there of how you achieve a uniformity, and that can even go to the question of ability to pay. For example, if some county says, we can't afford the 3rd or 4th year of this program, what might have to be done would be an analysis of the county's actual budget compared to every other county and say, well, you say you can't do this, but look here, you're 50% over some other county in another area. So these kinds of practices or checkpoints, I think, will become part of the system as you move along. And so the answer to those questions sometimes will get worked out on a case-by-case basis. But as long as you establish the basic principle of here's how you have to do this to participate, then eventually everybody kind of comes along with the thing. And we had to make some changes. You know, I don't know if you remember, but we eliminated the township assessors and we turned all the responsibility over to the county assessor. And we said, look, we don't care if you hire every single one of the township assessors to be your assessors, but it's got to pass this test of being assessed uniformly. So that's not an answer that solves your problem, but I'm just suggesting that this is how these things kind of get developed and worked out. The basic principles are you're trying to create a partnership arrangement where everybody is committed to delivering a good public health system. And secondly, you're trying to establish a major responsibility on the state to be the payor for a system that is going to produce a more equitable result between those places who can afford to pay and those who cannot afford to pay. And so if we can achieve that overarching larger goal, and I mean, I can't remember in all the years that I wrote budgets, there was never a time that we put a new program in the budget of this size other than an increase in the school funding formula. And the school funding formula is up $7-8 billion a year. So $250 million is a lot of money, but it didn't go very far in the school funding budget. But everything else was much smaller in dimension. And so I feel from my own experience that we're very fortunate to have a governor who is even willing to consider an initiative of this type that may cost this much money. Now, I happen to think that it sort of fits with all the other things that we've done in this state to be a good employer state, to attract good businesses, to get good jobs, to build an education system, to have a tax system that works for everybody. You know, I think we've been pretty successful here in Indiana compared to our peers. If you look at the states around us, Indiana is the only state of these Midwestern states that gained its population from the 2010 census to the 2020 census. And I don't think that was a happenstance. I think it was a result of how we did things. And when I look at the public health system that we have today, which is based on a 75-year-old statutory model, it puts all the burden on local units of government. I think this is the thing that needs to be brought up to speed with all the rest of the things that we have in our culture and environment to take care of our people and have them be healthy and have them help their lifespan. So it's, when you talk about this, you can't just say, well, is this going to be a problem? You got to think about that bigger picture. And that's what I tried to do here.
Okay. Senator Kinley, we have Mr. Tabor and Dr. Halverson with their hands up.
Okay, good.
Senator, thank you for putting this forward and all the work putting it together. I just, very brief comment about the duration. I think I really like that the formula, the proposal includes a commitment of 4 years. I think we have to have that to be able to do the work, the long-term work necessary to improve in this area. It can't be just a year-to-year arrangement. So just wanted to make sure that that was noted as well. I think that's an important part. I would think 4 years sounds like a good place to start. Maybe it needs to be 5, I don't know. Look forward to that conversation, but I think 4 years seems like a good place for us to begin this discussion. And I think it needs to be that type of duration for us to be effective.
Can you hear me okay? Dr. Box, Shane, can you hear me?
Hey, Brian, thanks for that comment. And actually, when I was kind of drafting this up, I was thinking of 4 years because most of the elected terms of office are 4 years. And then I was thinking of 5 years. And then the reason I was thinking of 5 was that kind of gave you a little carryover before the next crowd had to make a decision, and I ended up on 4. But I appreciate your comment, and I do think that's an issue that probably will be the subject of some discussion about what's the right amount of time going forward. Dr. Halverson, yes.
Yeah, can you hear me okay? Can folks hear me? Hello?
Yes.
Okay, thank you, Dr. Fox. Senator Kendler, we're very lucky and fortunate to have your sage leadership on this commission, and I certainly defer to your wisdom as it relates to how to make things happen in terms of appropriation. I would point out that one of the things that no one would want without, I think, in our counties would be access to substantial road funding. And similarly, I don't think they'd want to be without a fire department building or fire department or a police department. Unfortunately, all of those things are much more tangible than public health. Excuse me for being a little concerned, but one of the issues is that many people perhaps don't immediately see the benefit of public health. And I know that this commission and our report should go a long way to convince folks of that. But I just would remind us that one of the precepts of our work together was that getting public health services should not depend on where you live. And it just seems to me to be completely unacceptable for even having the possibility that somehow people, elected officials, would choose not to provide public health services, because I think that puts in an impossible position, because I do believe that the residual guarantor, if you will, is going to be the state health department. If the county chooses not to provide services, the state will have to step in, especially in light of public health emergencies that might arise. And I understand we don't want that eventuality. We don't want to provoke people. I understand all those things. But I do know that there are some states that have dealt with this issue. Texas comes to mind, where they have essentially developed a funding model that says that if the local county chooses not to fund public health, then the region, in the case of Texas, would have responsibility through the state Department of Health to take responsibility for public health services. It doesn't happen that often, although there are examples in Texas where that does happen. And that's one of the concerns that I have, is that while we don't want that to happen, I think we just have to recognize that the idea of not choosing to fund public health just can't be an option. Maybe it has to be an option in order to make the formula work that you've described, Senator Kenley, but I guess I'm just a little concerned about someone who's maybe putting not a lot of money in now, and we ask them to continue it, but with greater restrictions. How do we get them to come along to make sure that they're at least providing the small amount of money that they would need to? Thank you.
Yes, Carl.
Yeah, Mr. Chairman, I understand Dr. Helvertson's concerns and other concerns that have been raised, but I really am admiring and appreciate the framework you put forth to finally allow us to have sort of coordinated joint state, local public health funding that's predictable and funding that is tied to metrics that we all agree are necessary. And also appreciate that you obviously don't want to suggest a mandate at this point. The legislature could do that, but the framework itself, I think, is flexible, important, and I think something we should support. So I applaud you for putting it on the table. Thank you very much.
Yeah.
Chair.
Yes, Mark.
again, I think all of us are saying this is the right way to go. I'm looking at the back end of this right now because in our quick little discussion over here, there will be some who say autonomously, we want to be in control and we will opt out of this. What they're saying is we will, over the next 4 years, fund our health according to state law without your help. In about 2 years, they're going to find out we can't do that. And so are we going to continue to make them wait for the 4-year cycle, or do we allow them to opt in? That will be a question, because there will be autonomous groups that say, we're in charge and we're going to do this. And we need to lovingly support them in their misdirection.
Well stated, Mark. It wouldn't be too much of a change in the structure of the thing to say that if a county does decide not to take advantage of it, that they are responsible for delivering these services, but they can re-vote every year if they want to, until they decide to do it. I mean, that wouldn't really blow this proposal up. I think Dr. Howerson's concern about the state's going to have to step in and provide this is, in some cases, people who are going to want to play games are going to opt out in order to get the state to pay for something that they should be paying attention to. Part of it is not just paying for it, it's actually caring about what you're doing and paying attention to what you're doing. So it's hard for me to answer Dr. Halverson's question, because it does put that looming thing right out there of, hey, you may not have any services, even though by statute you're required to provide them. The way you stated seems to me a little more common reaction. Maybe a modification should be that should they take a vote and they decide not to do it and they go for a year and find out what it's really like, then they're entitled to re-vote, and then that vote would stand for a 4-year period or something like that. Those are
Congresswoman Brooks has her hand up.
And we're at the halfway point of the meeting.
okay.
Thank you all. Hopefully you can hear me. One way that maybe we could do what was suggested earlier is the public education portion of this relative to the county councils and the county commissioners. And if a specific county is deciding to opt out, that they would really be subject to having this education session that had been discussed. So they are really fully aware of all of the ramifications, and maybe have it in their own county, have the public education session about what, their decision might mean in their own county. And before they opt out, if a county is really thinking about opting out. But I think this is a great model to get started with. And I like the idea of the flexibility of allowing counties to come in if they do decide to opt out 1 year, that they are given the opportunity to re-educate themselves and change their minds. But I think they ought to be fully informed of what they're going to be missing out on if they choose to opt out.
Mr. Chairman, I had just a quick question, if I could. Mr. Chairman, this is Paul Halverson. I'm sorry.
That's a suggestion we haven't heard, and that's good. I think that has some merit, that maybe if some county thinks they're not going to sign on, then maybe the state needs to make a presentation or visit with them and talk through the whole situation so they can understand before they get into a situation what they're heading toward. That, I think that has some value and might take a little bit of the edge off of the sort of the brutality of the thing if you don't sign up.
I think we've kind of heard 3 tweaks. Mindy, you talked about making sure that, by maintenance of effort, that every county would be able to opt into this. We talked about the ability to revote if after a year or 2 years you realize, hey, we are really getting behind the times compared to other counties. And now making sure that the education exists. So those will be 3 things that we will work to incorporate.
Those are great ideas.
Those are really good.
Thank you.
Any other thoughts?
It looks like Dean Howerson has his hand.
Oh, Dean, I'm sorry. I'm
Senator
not used
Kenley,
to
thank
using
you.
this screen this way.
I'm sorry. Senator Kenley, I understand and appreciate the suggestions that have been made, and I like them a lot. I'm just wondering whether we would consider the idea of revising the required local services as part of the actions that we might take. The concern I have now is that the list is so sparse. So is there a way to perhaps revise those essential requirements at the county level?
That could certainly be studied. I think we could take a look at that and see if there's an avenue there to use that as part of the how you deal with these situations. I think that suggestion has some value too.
Well, I think for sure to receive the funding, there will be a set of essential services that will be required and need to be delineated clearly so that local health departments, county commissioners, and county council members
Right.
know what they're
Good
signing
idea.
up for. I don't know about going back and changing all the statutes. I mean,
Right.
that would be a job, and I think that could be something we set our
Yeah.
goals for going forward, maybe.
Well, maybe we need to at least put in the report, draw that in the recommendation report. Maybe that needs to be pointed out that might be something that needs to be looked at as this process is evaluated. And however, the governor may even choose to introduce the bill in a little bit different way than what we're talking about. And then the legislature would have an opportunity to.
Yep.
One of our funniest experiences was, most of you know what a good leader Mitch Daniels was and how firm he was in the belief in his ideas. And so first year when he brought a set of bills that he wanted to make his agenda, he sent them to us and he put on the note of caution there that we weren't supposed to change a single word in any bill because it would probably ruin it if we did. And of course, all of the legislators about died laughing at the thought that they weren't going to change a bill 100 times before it got finally passed. So that was a very interesting year in the legislature.
The plan now was to go forward and to look at each section to make sure that everybody has an opportunity to weigh in at their comments or concerns that they have.
Yes, thank you, Dr. Box. So the way that we've kind of crafted this is honestly based on where we've spent the most time previously with some of these conversations. You'll find those sections are towards the end in hopes that we can make sure we spend adequate time on these other sections as well. So the first section that we want to touch on is the data and information integration section.
Jane, can you get your mic a little closer to your mouth there? I'm sorry, I can't quite hear you.
How about now? No? Now?
There
Yes.
you go. Now you got it.
Let's go ahead and add to all these technological woes today. So data and information integration starts on page 65 of the draft report here. And what would be most helpful for me is, as members of the commission, if you have feedback or thoughts, if you could tell me a specific page number and kind of the thoughts that you have, we'll capture that and make sure we capture the essence of it and get that incorporated into what the final version will be.
Got this section perfect, huh?
I was just going to say, I thought Dr. Weaver and her team did a phenomenal job with this, and I don't have any additional comments or anything. I thought it was great.
How about online?
Any hands up? Dr. Halverson's shaking his head. So, okay.
Yes.
Yeah, shaking good.
Everybody's good? All right, we'll move to the next
I
one.
want to
All right.
comment, very brief comment. Hello.
Next, we'll do workforce. What? Sorry.
Very briefly, I just wanted. to,
Congresswoman Brooks.
Thank you. Just very briefly wanted to commend the report for recognizing what we heard from citizens about their concerns about privacy and making sure that, with respect to the data, that individual citizens' privacy is being respected and protected. We heard that loud and clear from citizens, and that was a priority in this data section, and I just wanted to make sure everyone realized that. Thank you.
Thank you.
Great. Next, we'll move on to workforce, which begins on page 55. And I know Dr. Maxey regrets not being able to be here today, but was really honored to be a part of this and be able to share this work with us. So happy to take recommendations or feedback on her recommendations rather. And I do see Brian Tabor has his hand up.
Thank you, Shane. Just glad you mentioned Dr. Maxey. She's a tremendous resource to all of us in this work and really to the state as a whole. And I do think there's a real opportunity here to tie together some of the incredibly important work of this commission with the work that's been done somewhat quietly, but has really been just such a strong, consistent effort over the past several years. It's a national model, and that's the governor's health workforce council. And one of the areas in which it's identified in the report that we need to enhance is data collection on that. There were also some other things that sort of struck me. I think it's on page 57, and I apologize, I have everything spread out here, so I have to reach for my papers and notes. It states at the top of page 57, no entity is formally charged with the development and oversight of a state plan for Indiana's health workforce. There's no formalized coordinations, and I know what we've talked about doing is elevating the work of the council. One thing that I think could be very helpful in increasing the capacity of our workforce, getting our applicants for licensure through the process faster, but also doing so in a way that provides for better data collection and better just coordination of the overall strategy, is to consider moving the licensing of our health professions under the Department of Health. Now, this is probably a big thing to throw out at this stage of the game. I recognize that. So I'm not going to insist that we vote on including that or anything. I realize it's a big ask, but I would like to just put it out there, and I appreciate the opportunity to raise it. And whether it's in the report or just in the conversation that we have following this, if we could maybe think about that a little bit and talk about how that could help accelerate the work of data collection, I think enhance the strategic approach that we need to take to our health professions, excuse me, in the shortages that exist. I think most states, many states at least, have their health professions, physicians, nurses, others, under the Department of Health. And I do think that there's the potential there. We know one of the things we need to collect is information on the unlicensed public health workforce, right? And maybe instead of moving that over into IPLA, doing that under the Department of Health would have all of that health workforce, the licensed professions and the unlicensed, under one umbrella. So I just throw that out for potential discussion here. Hopefully it's not too late in the game to just get our wheels turning about that on this idea, and just wanted to lay it out. So thank you.
You follow, I had a little trouble following.
His suggestion is currently licensure of healthcare professionals is through a PLA, Public Licensing Agency.
Uh-huh.
And that in many states, that falls under the Department of Health in the state, and that might help to better collaborate and coordinate
Okay.
not only the recruitment, but the retention and the licensure. Also, what he's talking about is that a lot of people that we don't currently license, but we have registrations for, there will be needs to have more of those individuals that are on a registry so that we have knowledge of their training and knowledge of their retraining and just our workforce that we have available.
You think that'd be helpful to put something in the report about that?
I'd be interested in what the rest of the commission thinks about that.
Yeah, Carol?
I, of course, have an opinion on that, and wholeheartedly agree with Brian. We talk about the need for expansion of the workforce in really all clinical and all public health areas of the entire healthcare industry, and we're preparing to do so, but at the behest of an agency that doesn't fall under the healthcare realm. And so there are and have been some significant delays in obtaining a licensure in Indiana in a number of different professions. And so when we consider those delays and what it's doing to our workforce, our healthcare workforce in Indiana, perhaps there are opportunities that the Department of Health can resolve and talk through on a much more timely basis agency in the way that it's currently set up.
Yes.
So I think the idea of having a central registry so that we know, for instance, we have another outbreak of something and we would have available who is a non-active nurse or non-active physician or non-active environmentalist, that sort of thing. I think that would be well within the purview to currently licensure of different positions is under different headings. And I think to try to take on that at this late stage would be a big ask. Now, that doesn't mean that under the workforce, I agree with recommendations. It doesn't mean that that can't be looked at a later date, but to try to licensure, I can just tell you from a physician standpoint, it can get pretty complicated because it's not just granting them license. It's also dealing with if there's a complaint against a physician, for instance. And then in some cases, you've got nurses covered under this heading, you got physicians covered under this heading, you've got chiropractors over here. So having a registry of who is licensed in the state or who has a background, I think that would be reasonable under these auspices, but trying to put all that under the State Department of Health, I think that would be kind of a separate big ask. Yeah, and it would be very complicated to put forth under our current circumstances.
Could the recommendation be and I don't want to speak on behalf of Brian, he might have a specific way he thinks the recommendation could be worded, but to further review or consider or
Maybe we could flesh out something of some of the problems that are involved in this and make a recommendation that this is an issue that because it crosses different people's jurisdiction, that maybe the administration would take on within itself a kind of a review of how this is done to see if they can't improve it. Maybe that would be a way to include it in the report, have it be brought to their attention, but we're not providing actually an answer of how you get it done. Would that be a workable way to deal with that?
I'd be curious to hear what Brian thinks. I mean,
Yeah, okay.
I'm
And I
comfortable.
want to
with
note
that.
Dr. Halverson also has the same.
Yeah.
I'm comfortable with that. If you can hear me, I appreciate it. I think just something that draws attention allows us to take a look at this issue. I think there's a great opportunity here. I realize again, kind of the stage that we're at, but I think looking at the report and the totality of the workforce recommendations, I think examining this area could really enhance the recommendations that we've already made. So Senator Kenley, I'm certainly fine with the way you phrased it.
Paul, do you have something to add there?
Yes, Senator, thank you for the opportunity. First of all, I would agree with Brian, and I've worked with several state health officials whose states actually have the administrative responsibility for the boards within the state health department, and it works very well. I don't think, to Dr. Welch's point, we're not talking about dissolving any of the boards. It's just where the boards report and where they get administrative responsibility or staff support from. So I'm very supportive, and I'm also very appreciative of which you've characterized it. But I have two other issues on workforce, one of which relates to the ideas related to the current public health workforce. And I fully appreciate that we want to cover all of the health workforce. That's really important. But I do think that we are in the midst of a workforce crisis in public health. And if you look at the national reports, particularly the workforce reports that are being established nationally, being run by the National Association of County and City Health Officials and the de Beaumont Foundation and others, they're calling for a substantial reduction in workforce and public health due to retirements and other reasons for why public health people are leaving their jobs. And that creates, I think, for us a really important responsibility to look at the current public health workforce, their training and their experience. You may remember the finding that many, I would say most public health professionals in Indiana and actually across the United States have no formal training in public health. And that creates a major, I think, opportunity of responsibility for us to look at ways in which to provide training, both formal training and in-service training. But then secondly, I think there are two issues that I'd like to bring up. One is related to the fact that we still have not addressed the training responsibility, the public health training responsibility for our public health administrators. And I know we had a little bit of a conversation last time about health officers, and I think that got a little off track. I think the idea here would be to clarify the responsibility of public health administrators and to require certain public health training over time with provisions for phase in and transition. But we do need to recognize the importance of our public health administrators and the responsibility that they have for training. And the second issue is related to a suggestion that was made by a couple of other commissioners, I think, in previous meetings, and that is the importance of developing statewide salary classifications for public health people. They're leaving each of the classifications to the discretion of the individual counties really creates enormous vulnerabilities and variation, particularly in positions like public health nurses, environmental health specialists, even public administrators. We really run into a problem because many of these salaries are not kept current and are unable to pay, frankly, a competitive wage. And speaking as the dean of the School of Public Health, I can say we have many people interested in public health jobs, but our pay classification systems, requirements, and salary schedules are just not at all competitive. And I think we could do a great amount of benefit to the state by essentially developing statewide pay classifications are minimum salary levels for key essential public health positions. And so, again, I would just add that in the consideration of the commission as we consider the workforce report or the workforce sections. Thank you.
All, with respect to Brian's recommendation, it seems to me that we could put that together and ask the executive branch to try to work their way through some of that, and I think that could be doable. On the statewide salary schedule, I can't think of any place, Indiana government, where we're doing that.
It's
Dr.
very
Box?
common in hospital care and in hospital
Hospital
systems
care.
and physician care. I mean, that kind of salary range. And
Right,
it is something that I think if we're going to increase funding and expect to maintain good people and for them to be trained, we probably ought to give our county commissioners and councilmen some direction on what that salary range would be.
okay,
Looking at nationally what that tends to run, maybe.
yeah. That might be maybe just a review of that at least to bring it to their attention. When I think of like the schools, we have 320 school districts with 320 salary schedules.
Yeah.
And so if that is something that, if you think we could improve the report with at least some guidance on how that's done, to at least plant the suggestion, is that what we could do?
Yeah, I think to show that we need to have direction in that way or to help. I would listen to our county commissioners also.
Yeah, I was going to say, and certainly something in here that's going to mandate that because it's going to the wages and the so on. So that's the way it's going to happen. But I think putting something in that would certainly allow for recommendations or something like that, I think is very good. And you know, it's the people who are going to be the ones carrying public health. That's the critical piece of this. We can have all the stuff in this report we want, but if we don't have the people to do it, it isn't. Train the people, recruit them, and retain, then the work isn't going to be done either. So, yeah.
With what Dennis is saying, and as well, we do get some mandates in probation. Salaries are.
That's right.
From the state. So-
We did have that issue.
So
It was pretty controversial too, as I recall.
pretty much, anytime we get the directive, they have to raise it. So.
Yeah.
There's
I think-
at least a standard for us.
That came from the Chief Justice.
Mhm.
And the legislature they spent almost the whole session trying to override him. So, well, Chris, you seem to have a feel for what we're talking about. Maybe we
I think
could,
we could work
Okay.
to get some language in the report around that.
that'd be great. Let's try that. 30 minutes, okay. This is a little hard when you're having delayed conversations and
Yeah.
It's a little more challenging.
Anything else on workforce?
yeah.
And I will note, I did hear Dr. Halverson's concern about local health administrators. And so it sounds like what he's asking for is establishing some guidelines around what those qualifications might look like. Correct?
At least defining the position. I think that's going to be a requirement of public health across the state is what is a particular position's job description? So working with our local health departments to help do that.
Next is child and adolescent health, and that begins on page 87.
Excuse me, Shane, what page did you say?
87.
87, okay. You're jumping around. Fine.
Yes, we are. Sorry.
And then I will note that Dr. Halverson has his hand up.
Yes, the only question I had is whether or not we were able to nutrition in both education, vision of nutrition information and guidance and so forth in the child and adolescent section. I thought that was a really important addition, especially with childhood obesity as it is.
I thought we made those changes, Shane, in the report, or am I incorrect?
On recommendation 27, I believe we did add physical activity specifically there to try and address that. But if there are more specific language that folks would like to add, we can look at that.
I think that Dean Halverson's comments are what he means is, to me, the division of nutrition and physical activity includes good nutrition. It includes removing bad nutrition, like in the form of vending machines and the exercise in schools. But I think we didn't delineate that. So Shane and I will review this to make sure that that is clearly delineated as an important aspect of nutrition and physical activity.
That sounds good. Everybody agree with that?
Yeah.
Okay. Yes.
I think it looks very good with that addition.
Thank you.
I would say I'm sorry, go ahead. I think this area is the action items or the information in school nurses and the work healthcare facilities and the school nurse working together there. I think that's very good. I think we need to keep building.
Comment is on 26A, and it might be my math brain, but reducing the ratio, it seems like we want to increase the ratio.
That depends on which way you look at it.
We want more professionals.
Yes.
Per students,
Yeah,
right?
and we can say that in a different way so as to make sure
Sure.
it's clarified. Okay.
Yeah, that's
Yeah, it might
potentially,
not, yeah.
First time I read that.
That's-
Different language. We want to reduce the school
Yeah.
counselors.
Okay, thank you.
that's a good catch.
Sorry, which recommendation was that?
26.
26A.
Yeah.
Instead of the word reduce, we need improve or something like that in there.
Increase the number of school nurses per student.
Thanks.
There you go.
And
Pretty
it,
straight.
it was actually pointed out to me, just going back to the previous point, recommendation 28C does say support policies to increase the availability of nutritious meals and reduce the availability of non-nutritious food in schools and early childhood education settings. So I think we might have captured that just in a different area.
I thought you did, but I'm missing it on here. Where is it?
I have slept since then.
28C
28C.
28C.
at the top.
It's on page 96. Yes.
Oh, yeah.
Increase the availability of
Yeah,
nutritious
I
meals.
thought we addressed that.
Yep.
We talked
got it?
about it anyway. Thank
Yeah.
you. Do you see that, Dean Halverson, 28C? It's on page 96.
Yep, he's giving a thumbs up.
Okay, perfect.
Any other comments or feedback?
Well done.
Okay, moving on to emergency preparedness, which I lost track here. I have too many papers in front of me.
The recommendations are on page 85.
Yeah, there we go. Five.
Nail this one too, really? Oh, Mindy, of course.
Sorry.
No, don't be.
I know this sounds like a broken record, but I said this last time. I just kind of want to understand why we would require everybody to apply for that particular grant, but no other grants such as immunizations. It's like I'm trying to understand why we would require them to take that, participate.
From a recommendation 21.
So yes. 21.
To my mind, one of the biggest issues throughout COVID was the lack of coordination at the district level for emergency preparedness. I think that we were able to get everybody together, but not necessarily through the traditional means of the healthcare coalition, which is the way it was designed to happen by the national federal leadership. And I really believe that there's work that needs to be done there, and it requires, and you have a person who does this, but many places in the state don't have a person that even has a half-time person engaging with us at the district level. So this was something, and I had this discussion with Director Cox, that they felt very strongly about from an emergency preparedness standpoint, was requiring that 0.5 FTE that is devoted to being engaged in those district meetings and actually planning together with the counties around them.
And can you just require that versus participation in the entire grant?
No,
I'm
Is
not,
there a problem with being in the grant? Is there
I
a
guess I
barrier?
just not understand why we're calling out that specific grant. There's what, 10 other grants and of importance this year, we've been was immunization, but that out and having a specific number of nurses. I just don't understand it. So if it's a thing you want. There's a lot of training that goes into that type of person. So I'm just wondering why that's called out like that.
Well,
I
let
just
me
don't understand it.
let me offer a thought on this as somebody who doesn't really know what we're even talking about. In some, it seems like things like emergency preparedness and getting ready for the pandemic and other things that happen like that, and the things that the emergency preparedness office and the Homeland Security people have to do. Everybody says that's something you should do, but whenever it comes time to actually doing it, it's about the last thing on everybody's list because they think they have other more immediate things that they should be responding to right now. And so I kind of understood it. It sounds like a mandate, and it is, but I kind of took it to mean this is the kind of thing that you need to pay attention to. But unless we say you have to do this, they're just going to ignore you. And so I didn't worry about it from that perspective. I thought, and when Mr. Cox made his presentation, he made a lot of good points that I thought we should have thought of this. We should do that. But I think everybody tends to push those things to the back burner. And so I'm not too worried about having that in there in that form for that reason. I don't know.
I will say, and this was probably 3 or 4 years ago in meeting nationally with people, the thought process was, if you can't even get your counties to engage and take this grant, you're going to put this grant at risk for your entire state or your entire district. I have never seen them follow through with that. And I really kind of cry baloney on some of that, but it would be really hard if after this pandemic, then we had the federal people say, you're all doing it or you're not doing it. And that would put it at risk for every other county that does want to have that grant to pay for that 0.5%. Again, I don't know if that would come to fruition.
Dean Halverson and Brian Tabor also have comments.
Thank you, Mr. Chairman. Two comments. One related to Dr. Box's comments around emergency preparedness, and having been at CDC and pretty close to the action on emergency preparedness, I would agree. The statement that's frequently made is that we're only as good as our weakest. And if we don't have a strong public health coordination of emergency response at the local level in each jurisdiction, it really breaks down quickly. So it's hard to imagine not having that requirement. And I understand no one likes requirements, but I think that's important. But my issue related to this section, it goes back to, I guess I'm sorry for being a broken record, but the leading cause of preventable death for everyone between 1 and 44 is trauma. And we have a problem in Indiana in terms of our trauma system. We do have a trauma system. It's not fully funded. It's not properly funded. And we have particular issues as it relates to the linkage in our rural areas, particularly with EMS and linkages with our ambulance systems and a whole host of things. The other thing that's important to recognize is the leading cause of death for people over age 60 is accidental falls. So falls, and for everyone over 60, and the leading cause of death is between 1 and 44 is trauma. And we're not, in my opinion, putting a strong emphasis in injury prevention and control. And it's really, really important. It's frequently not given the attention it needs. And I'd like to have at least some section in here that says that we place importance on injury prevention and control, and specifically the importance of our trauma system. And Dr. Box assures me that we're going to the American College of Surgeons review, but we need to also look at our rural system and our hospital and ambulance linkages, particularly county to county transfer of ambulance services to designated trauma centers, so forth. So I sure would appreciate it if we could at least talk about trauma and emergency services, in particular as it relates to injury prevention and control. Thank you, Mr. Chairman.
All right, I'll go ahead.
Recommendation 23 addresses, and it's on page 86, conduct a needs assessment of specific EMS gaps in local jurisdictions, ensure funding for prioritized recruitment to address EMS workforce shortages, and provide mechanisms for cost sharing related to equipment purchases, particularly in underserved and geographically remote areas of the state, establish long-term promotional and retention plans for EMS personnel, enhance ongoing higher levels of EMS training and expansion of community paramedicine programs, improve health outcomes related to trauma and injury through enhanced analysis of these issues, increased access to EMS, and strengthening our trauma system. And the letter for our request for evaluation by the American College of Surgeons was just signed by myself. So it went out. Lindsay and her team are on top of that. Is there further recommendations, Dean Halverson, that you would like to add to that? Or I just want to make sure, and I know Dr. Welsh, you're on the trauma committee. Tell me what, I'm happy to add additional.
Well, Dr. Halverson kind of beat me to the punch, but with your response, I'm extremely happy.
Okay. All I just read, I swear to goodness, I didn't make any of
Well,
it
the
up.
fact that you signed the letter, I think that adds.
Oh, the ACS,
Yes,
okay.
right.
Yes.
So that goes a long way. I was going to say, I really like pages 81 and 82. And with your explanation, I'm really happy with the recommendations and knowing.
Well, I think
that's the story.
for your benefit, Dr. Welsh, and for Dr. Halverson's, in my thinking, recommendation 23, which doesn't break it down and articulate it quite in the way that we're thinking about following up on those recommendations, I feel like this is one of the areas that we can make a strong presentation, not only in our recommendation to the governor, but in dealing with legislators, that we have discussed making a pretty high priority out of EMS equipment and EMS training as a real shortfall, and that will be very attractive to many rural legislators in a lot of areas. And so we think, I think the way it's written, when you put some meat on the bones there with what we think our effort's going to be, I think this is going to be one of the highlights, one of the first most noticeable things that we maybe accomplish that the public will know is actually going on. So I think we'll be very strong in this area in terms of implementation if we can get the funding and do what we need to do.
Mr. Chairman, if I could, Mr. Chairman.
Perhaps we address it in the funding section, and I'm just not recalling immediately, but when I look at page 80 and we talk about, some of the reasons for lack of available EMS, I think we address some of the things in the recommendations. One thing I don't know that we are addressing is the bottom couple bullets on page 80, reimbursement for 911 transports based on mileage and not services provided. Inadequate or no reimbursement for transport between facilities, leading EMS providers to decline, and that the agencies are listing lack of funding as the number one reason for a decrease in EMS services. Maybe I'm overlooking it, but we don't really provide a recommendation to address those three areas, at least in this section. Perhaps it's in the funding section that we'll get to here in just a moment, but
Where are you looking at? Kara?
page 80 and the
Okay.
last three red bullet points.
Okay.
And those are definitely issues where EMS goes out, maybe they don't transport someone, that they don't
Right.
get paid anything for it, or they transport between hospitals and they don't get paid anything for it. So those are real issues that I don't know that we did address them separately in the funding part. At least I don't recall. Lindsay, do you recall any specific? So I think you're right. We may need to incorporate that into recommendations, maybe under 23, or what, do you guys agree with that?
Yeah. Well,
Would
and some of
that-
that is tied to the payers as well, and the restrictions that the carriers or CMS may have
And-
relative to Medicaid and Medicare.
I wondered if it
really
was a
back to the-
negotiation issue, those
Yeah, the
negotiated
treat no
rates.
transport policies. So it's something we can certainly look into more. But I think some of the scope of control lies outside of the state with respect to that.
So maybe just a general further evaluation of and determination whether any of this can be improved.
I
or-
think that's fair, because I agree. I
This is-
think you don't want to get into legislature mandating rates. Like, we don't want to go down that road. So I think that's a fair statement. I didn't see it in here, because it was listed as the number one issue
Okay.
for EMS
Mr.
providers,
Chairman?
we did feel like we needed to
Sounds
address
like we
it,
need to do a little more there.
at least a recommendation for
Yeah,
evaluation.
Great. And I think Dean Halverson is still trying to chime in. Sorry.
I'm sorry for the delay. It's really hard. But I think 2 points. One is related to the ambulance transfers, and the issue there is that you can have a wonderful trauma system, but if you can't get the ambulances to cross county lines to take patients where they need to go, it doesn't work. And we could take a page out of the book of the mutual aid arrangements that fire departments have. Other states have solved some of those problems in similar ways. I don't think we need to prescribe it, but we definitely need to address it. And then the last thing to say is related. I don't see anything really here related to injury prevention, Dr. Box. I really would like to see us make sure that we talk about injury prevention, and it's one of those things, whether it's in engineering or in education, there's a whole host of things that can and should be done in injury prevention that I think would be big evidence. Thanks.
Thank you, Dean Halverson.
Brian, so I want to read into the record just for Brian. He put a comment in that said, I'll pass on commenting due to the delay. I just wanted to make sure that with the FEP coordination, this is important. One of the lessons learned from the COVID pandemic is the need to convene and mobilize quickly and effectively across 92 counties. There are other elements in the report, such as realigning the FEP districts, that add up to needed reorganization of this whole system. And I think we need to look at recommendation 21 as part of a greater whole. He's giving me a thumbs up.
Thanks, Brian. So we have injury prevention under the childhood and adolescent, but we can definitely add that to the emergency preparedness part
Because
too.
it's really more the adults, I
Yep.
think, that we're looking at.
Got it.
If I may make additional or comment, I agree with all the discussion. Part of this, I think, and it's commented on in recommendation 23 about workforce, but this involves workforce. It involves aid to these people as well. But the state of Indiana, I'm sure, is finding, and we're all finding under that there's major metropolitan areas and rural areas got a mix of volunteers and paid folks, and the volunteers are, so it's leaving a void in a lot of areas to provide appropriate EMS services across the state. And I think, seeing it appropriately, I mean, we're facing it out in Hendricks County. We've got the east side of the county that's fully covered, paid folks, and you got the west side of the county that's all volunteers. Comment is, don't have a heart attack. If you have a heart attack, make sure it's after 7 p.m. at night if you're on the west side of the county, because the volunteers will be there. Those are some of the things we face.
And would you feel comfortable with the conduct and needs assessment of specific EMS gaps in local jurisdictions would be a good start then to address
That's
that?
A, yeah, that's your comment A, yeah.
We think that in our discussions, we think that this is going to be a point of high interest with legislators. And we think that this is going to be an asset for us because most of them are going to want to solve this problem.
Yeah.
And so although there's a lot of recommendations here and it kind of all blends together, there are some that are more actionable than others. So I think we'll make some progress on this. Hopefully it won't end up like the discussion of the paid versus volunteer fire departments that we had. We never did unravel that puzzle. I don't know. Okay.
Any other conversation on emergency preparedness?
Comments, though, you guys, really good catches.
Yeah.
Thank you. I
Right.
can tell you've really looked at the
No, they're
report.
very good.
Thank you.
So the next work stream or section that we have up is governance and infrastructure, which is towards the beginning. That starts on page 31. And those recommendations are on 41. Kim?
Yeah, so I do think that the language that we reviewed last time regarding health officer expansion was not reflected. So, okay, thanks. I had mentioned it to Shane, so.
Yeah, and specifically, she's talking about that one option that we had proposed the last time that would allow a local jurisdiction to propose a solution different than an APRN or a physician's assistant or a physician with approval of the Department of Health's executive board. Somehow in our transcription, we missed adding that in.
Oh, okay.
Sorry
got
about that. I'm
lost.
glad you noticed that.
All right. Thanks, Kim, for reminding us. Anything else in this area? Yes, Dr. Wells.
So I just, so the commission is aware, I know there will be some MDs and DOs who are going to be resistant with the APRN and PA, but I do have to commend the staff and everybody working on making sure that if that were to be utilized, it would be they would be working under the direction of a physician.
Right.
And I thank Kim for bringing up the other point that when we had the discussion that at any time that would be asked for, it would have to be approved. The whole setup would have to be approved at the state level. So I appreciate Kim bringing that up. Other than that, I think it's great.
Any other final comments? Okay. I know we talked a great deal about funding. That does begin on page 44, and those recommendations start on page 53.
Was the 2019 national average?
There are more current ones available on, I believe it's the Trust for America's Health. However, it's inclusive of COVID-related spending. And so we tried not to use those data because it would muddy the waters in terms of what we were actually trying to fix baseline level. Yeah. Congresswoman Brooks actually asked us to kind of call that out a little bit more so we can explain that a bit better.
Does that need to go down as a, okay.
Their comments?
I have one.
Yes, Karen.
And I mentioned it to Shane. In the report, we talk about, we want to make sure that this is perceived as one-time funding fix is going to take care of this. Like, we just need a bucket of money now and then we can go back. And it did feel like some of the language, like in recommendation 9A, where it says request an increase in annual appropriations for 24-25 biennial budget. I just don't want legislature to go, okay, well then we can change the 24-25 budget and then we can, revert back to how it was, or I just don't want to.
Needs to be reflected that it's more of a permanent.
It is, it's subsequent years or subsequent funding years or.
That's a good comment.
And we did talk about increased, consistent, and flexible funding even through the local health maintenance fund. And I think maybe
That's
we
fair.
should be really
Okay.
specific
Yeah.
on that.
Yeah,
We'll work
that's
on that a
fair.
little bit. Their thoughts or comments? Yes.
I
Dr.
just really appreciate the fact that the local health maintenance fund is included there prominently, because that is really key to successes at the county level. Thank you.
Agree with that?
Additional comment would be, I don't know if starts this section out on recommendations, and it goes right to what the national average of $91 per person is. Will legislators know where we are now? Where the funding is now, so they see that. I mean, it's staggering when you see it, and maybe they're going to say, whoa.
I think we can clean that up.
I agree. I think it's a
Yeah.
good thing to point
That's
out
a
there.
good point.
It's in the body of the report, but we need to pull it into this in case
Right,
this is
it
the only
is.
thing we
Right.
look at.
Plus, that's kind of where you figure the basis of what's the difference and what's the increase you need. You
Right.
need to know
Yeah.
which each of the 2 points are.
Yeah.
So,
And-
okay.
Just to tag onto that, we talk about the difference excluding Marion County in the report, because I think Marion County does skew the average across the state. So I don't know, you don't want to get the recommendation so lengthy that it is a report, but we may want to figure out how we can embed that into.
Say that accurately.
Yeah.
Okay.
Okay.
That is all the work streams.
Is this it? Okay. Let's walk back So Chris, you've made quite a few notes there.
Actually, sorry, Dr. Halverson just quickly noted, should we say that we should be at the national average? Should we say that we should be at the national average? Right now, the recommendation says spending comparable to the 2019 national
So
average.
what page is that on?
53?
Oh, be at the national average.
Or course, that's going to change, you know, you can say.
Want to always be locked
Years,
into
that's gonna change.
just that number.
I don't know.
A goal to reach and minimum be at the national average.
Let us work on, I don't think there's any disagreement about
Yeah.
making some changes to make improvements. Let me take you back to the original conversation at the beginning of the session. My thought is that you all have put in a lot of work very diligently and faithfully for about 10 months here. And the staff has just done incredible work and revisions and more work. And so I think we have despite all of the discussion and probably a number of points that we're going to need to make corrections to, my thought would be, I wonder if we could take a vote today on approving the report with the modifications to be made, and then let Shane and the staff work on improving the language on those things and just send them out to all of you for maybe comments and corrections and adjustments or improvements. But that we go ahead and accept the report and make the be prepared to make the recommendation now without having another, because really all we have left to do is to vote. And I kind of hate, I feel like I know how much my time has been intruded on, and I hate to make you all go through any more than this. And I hope, Dr. Box, that we can figure out some way when we do make the recommendations to the governor that we give the members of the commission an opportunity to be involved in some kind of a little presentation or event or discussion or something like that. And I'm perfectly happy to call Earl and say, we want to schedule a time in the governor's office to just present this to you and talk about it for a few minutes. And maybe you have a little 1 or 2 page white paper that we can use for selling points. And we would like for any of you that would like to participate to be able to come and do that. I think that will help the effort. But the real question is, do you feel comfortable taking a vote today to say we approve the recommendations of the commission? And then knowing that you're going to get some corrections, improvements, additions, maybe a few deletions on 10 or 12 points, and you'll have an adequate opportunity to review those and continue to further refine those.
You've got all thumbs up and
Yeah.
yeses on virtual.
Everybody's seen
Dr.
enough on the
Yeah.
virtual crowd.
Dr. Halverson so moves, and Brian Tabor says yes.
So Dr. Box, Shane, do we want to take a vote? Quite often, going back to the legislative days, we take a vote in the Senate, we'd say, can we take that by consent? And everybody says consent. Or do we need to do a roll call vote? Or
We need to do
what
a
you
roll
wanna
call
do?
because it's virtual.
Pardon?
We have to do a roll call because there are people virtual today, so that's a requirement in the executive branch.
So we need to do a roll call.
Yes.
Okay, Shane, it's your
All
call.
right.
He's our parliamentarian.
Can I get a second for the motion?
Yeah.
All right.
So can I have a motion that we adopt the report with the additions and corrections and deletions to be made and reviewed by all the members?
So moved.
Second?
I'll second.
Okay.
Okay.
Thank you. Does everybody understand the motion?
Dr. Box,
Yes.
Dr. Monroe,
Yes.
Senator Kenley,
Yes?
Mr. Ellison,
Yes.
Mr. Tabor. Yes. Dr. Veal,
Yes.
Ms. Irwin,
Yes.
Ms. Waldron,
Yes.
Dr. Halverson. Yes. Mr. Welsh,
Yes.
Commissioner Bardsley,
Yes.
Commissioner Dawes,
Yes.
motion passes.
Mhm. I forgot to thank one person.
Yes, Dr. Box, the floor is yours.
We received funding, and I said this at the very first meeting, from Claire Fidian Green and the Fairbanks Foundation to be able to do this. And they are sitting here today, and I do want to thank you for facilitating this. This has been incredibly important. And you also facilitated Dean Halverson and the Fairbanks School of Public Health's report for 2020, which really set us on the path to where we needed to be and has helped us tremendously. So thank you for that.
Thank you very much. Anything else before we adjourn? Yes, Dr. Welsh.
When this goes before State House, I would offer my time and efforts to go before our elected officials to,
Believe me, the battle has only begun.
yes, sir.
And we need everybody armed and ready to go.
All right. Thank you all very much for your work and your help and your assistance and your leadership. This is really, I headed up the Property Tax Commission and the Gambling Review Commission. And in both cases, we took hearings for what seemed like 30 days. And then I got to sit down and write a report on my own after we were done. So thank you all for your work on this. Yep.
Thank you.
We stand adjourned.
Thank you all.
Very nice work.
Sure, neighbor.
Okay.